missed, and it is not properly managed also, with maybe some minor symptom management. We may be able to reverse the causes that leads to delirium. Uh, Even simple constipation can produce delirium. Uh, so there are many factors which can produce delirium, but in palliative care, uh, that there are some common factors. Some are risk factors, and there are precipitating factors which can precipitate delirium. Uh, and management also is simple, but Dr. Roop Gursahani, who is a consultant neurologist at PD Hinduja Hospital, will be handling this session. And he is very much interested in neuro palliative care, and he's working as a member of End of Life Care India in India Task Force. So he will be talking to you regarding delirium. Sir, it's over to you.
Thank you. Am I audible?
Yes, sir, you are.
Hello.
Yes, sir, you are audible.
So, okay. So I need to share my screen. Yeah?
Yes, sir.
Right. Here is this. All visible?
All visible, sir.
Okay. Thank you. Thank you to everybody at Delirium for having me again. And in some ways, this is one of my favorite topics. So let's see whether I can convey some of the sense of interest that I have in this particular topic of delirium, not just in palcare, but also for all of us. Now, one of the things about delirium is that it sits on the boundary between multiple disciplines. Neurology, psychiatry, internal medicine, intensive care, palliative care. Everyone needs to know about delirium. And as you can understand, everybody's business is often nobody's business. So just a little bit of housekeeping to start with. Let me take you through how you look at alterations in arousal. So you are looking both at changes in attention and changes in arousal. Now, alert refers to a perfectly normal state of arousal. Though, of course, you can have people who seem to be alert, but are agitated pathologically. And this is basically loss of control from the frontal lobe. So the whole brain is not really working well. Then comes lethargy or obtundation, which lies somewhere between alertness and stupor. Stupor is a state of baseline unresponsiveness that requires repeated stimulation to arouse. And coma is a state of complete unresponsiveness in which the patient lies with the eyes closed. So you can understand that only alert and comatose are really clear points. The other two are a little vague. Another way to look at it is consciousness is a state of awareness of self and surroundings. So you can have alterations of attention or arousal. And remember that the only normal form is sleep. And in some ways, if you exclude sleep, then you're looking at various conditions that cause acute or acute on chronic brain failure. Now, that's not a term that is commonly used, but effectively it is just that. It is because the brain is so complex an organ that you don't think of it in terms of brain failure in the same way that you look at heart failure or kidney failure. Then, of course, you have alterations in the content of consciousness. And there you have dementia, psychosis, depressions, all of those that affect cognitive and affective mental function. These are the various elements of chronic brain failure. So let me begin with three clinical stories. And the first is, if anybody of you is interested, the presentation in any case will be shared with you, and you can actually read this because the story is free on the net. I'll just shorten it for you. So this is the story of a Polish worker. I think he was a manual worker, and he uh, had planned to migrate to Canada. So he landed in Vancouver on the 14th of October 2007. And he came with his mother. And for 8 hours, he was stuck in the immigration lounge waiting for his mother while she had gone through and she was on baggage claims area. And because of the English problem, the two could not connect. And this guy got more and more confused, irritable. Finally, he built a makeshift barricade to make sure that nobody could remove him from where his mother was supposed to be coming. And then he began to started to get violent. Computer equipment being thrown on the floor. The police were summoned, and he was pinned to the floor by the security officers. And somebody used a taser on him. A taser is something that gives a sharp bolt of electricity and can stun people. But Zikansky died. Now, this is something that you're unlikely to see in palliative care, but still, it's interesting. The excited delirium syndrome has six or more of these signs: pain tolerance, near constant physical activity, superhuman strength, rapid breathing, often sweating profusely. So you have a multitude of symptoms that you may have seen in individuals who, well, die in police custody. And they actually have a risk of death of 6.3%. So there is a pathophysiology there which is similar to that in psychostimulant abusers. And it's got to do with central dopamine transmitter function. And that causes manic excitement. So there's been some amount of literature on this, and I think we've all seen cases of this, even we've heard of cases of this in the newspapers, even in the recent past. So that's case one, unlikely to come to palliative care. Okay, case two. This was a lady with a history of breast CA, but treated. And one day she went to bed after lunch with a headache, woke up lethargic, confused. By the time she came to casualty, her neck was rigid, she had fever, leukocytosis. The CSF turned up the classic picture of um, uh, pyogenic meningitis, and with treatment, she was completely normal. The third is the real challenge. This was an older lady who had a fall in the bathroom, and before that, she had been completely independent. Fracture neck femur. She came to us after a couple of days. I saw her pre-op fitness. There was a history of stroke, and there were no focal signs. And she even did not have a bad mini mental state, 25 by 30, which is above the cutoff for dementia. But the next evening, post-op, she was agitated. She needed to be sedated. She ended up aspirating, went to the ICU, spent 10 days there, mobilized, discharged 3 weeks later, and on discharge, her MMSE had dropped by a full 10 points. And even a year later, it had not recovered. And this is sometimes what brings patients to us from geriatrics, but also, of course, in neurology and so on. These are individuals who are normal functioning and some kind of catastrophic event. For younger individuals, it will be stroke or traumatic brain injury, but in the elderly, it could just be hip fracture. And these patients then decline precipitously and remain like that till death. You may have been told over the four trajectories of at the end of life. This is the fifth trajectory that was, in some ways, recognized sometime after that classic paper. So, to come back to the point, delirium represents acute brain failure. In our first patient, it was overwhelming physiologic or pharmacologic stress, perhaps in a genetically prone individual. Then the second was a normal individual and an acute severe neurologic insult. The third was a vulnerable individual who had an acute or subacute systemic insult. She had the stress of pain, of this fracture, then post-op, and then post-op issues. So it's important to realize that the risk of delirium will depend on both the precipitating factor and the predisposing factor. And if you can see this slide, if you have somebody with dementia, it will take just an uncomplicated urinary tract infection to put them into delirium. Whereas with pneumonia, probably somewhere in between. And in a cognitively intact individual, it takes sepsis with multi-organ failure. Remember that when you see terminal delirium in individuals with cancer, you are seeing individuals who are probably cognitively intact, but as active dying begins, sepsis sweeps the body. There are three types of clinical delirium that we recognize. The hyperactive type, agitated, restless, tries to remove catheters, tubes, hitting, biting, and so on. Hypoactive, the other extreme, withdrawn, flat affect, apathetic, lethargic, and very often you get the mixed type where people cycle in and out of both. If you look at literature, the hyperactive type actually is not very common. The commonest type is mixed or hypoactive. In fact, hypoactive delirium, the problem with it is that it is not very often recognized. People just miss it because you don't check for it. So the neuropsychologic features of delirium start off with a reduced ability to maintain attention to external stimuli and to shift attention to new stimuli appropriately. So they cannot keep track of what is going on around them and the environments that they are in. Disorganized thinking, so incoherent speech. They cannot register information, so memory gets impaired. Then because they are uh, disoriented about where they are, they start seeing uh, things which are not there. So hallucinations, but also illusions. And sometimes they may actually not recognize people who are well known to them. There may be increased or decreased psychomotor activity. But probably the hallmark, the most common feature is a disturbed sleep-wake cycle. So these are individuals who sleep through the day and stay awake through the night. They're disoriented when you, uh, so- sorry. They're disoriented in time. They have changes in mood, and they have tendency to fluctuations, especially nocturnal exacerbations. Sorry, just a sec. Yeah. Okay. So the essentials for diagnosis are a change in cognition, which consists of disorientation and perceptual disturbance. And you can also pick up language disorder, not full-fledged aphasia, but typically they will not be able to name objects on confrontation. So you give them a mobile and they'll say pen hai, or stuff like that. And this is not accounted for. I mean, in the sense that there is no clear uh, way to figure out whether this is dementia, except that the person before this was functioning at a much higher level. The course is acute or subacute, with an onset over a short period of time, fluctuates, and typically it gets worse at night. But essentially, delirium is a failure of attention. And you will understand it by realizing that attention is the way the brain puts a spotlight on the various brain regions that are in play at a given time. So on the stage, it may be two, three, four, multiple areas of the brain that are active. And attention shifts between whatever is active. So you can understand that very obviously this would be due to loss of efficiency and deterioration of the networks of the brain that connect the various active regions, and that has been confirmed on investigations. There is a lot of literature on the neurochemical mechanisms of delirium, and this is important because people have looked at various pharmacological options, but the way these various neurotransmitters uh, uh, are not too predictably or consistently changed depending on the pathology, that it becomes difficult to pinpoint one single reason. If you were to try and remember this, well, there are two mnemonics that you can think of. Delirium itself, D is for drugs, especially those that have significant anticholinergic effect. E is for eyes or ears. This means people who already have sensory impairments, low oxygen states, infection, retention of urine or stool, ictal. Post-ictal means after a seizure, epileptic seizure, uncontrolled pain, metabolic, and not to forget, subdurals. Or even more dramatic, I watch death, infection, withdrawal, especially alcohol withdrawal, but could also be benzodiazepine withdrawal, acute metabolic, simple things like hyponatremia, head injury, CNS pathology, like a woman who had a pyogenic meningitis, deficiencies of thiamine, of B12, they can both contribute, endocrine, hypothyroidism, acute vascular, even myocardial infarct can present with delirium. Toxins, drugs, heavy metals bring up the list. But I'd like to take you through three specific conditions that I'd like you to remember. One is delirium in cancer patients. And here you will look at a host of disorders. Leave aside intracranial involvement by the malignancy, medications, medication or substance withdrawal, infection, organ dysfunction, endocrine, all of these, including the adverse effects of radiation treatment or chemotherapy, all feed into brain dysfunction. And chemotherapy encephalopathy is a very poorly recognized entity very often by even by oncologists. In this year, how can I forget COVID-19? So, COVID patients in various studies have been shown to have approximately 50% or more incidence of delirium, and there seems to be a direct effect on the CNS. This was from a review. But almost at the beginning, this paper came out in June 2020. A 73-year-old man who presented with confusion in the absence of any respiratory symptoms or even fever and turned out to be COVID positive. Subsequently, more patients, such patients have been described. So COVID-19 is something to remember. And then this is something that you should never miss. If you have an elderly male comes in with a rapid onset of delirium, may have a history of urinary symptoms, and when you examine him, there is suprapubic fullness. Just putting in a catheter will rapidly reverse his delirium. It's been called the cystocerebral syndrome, and there are a certain number of cases reported. I know about it because I actually had a patient, and unfortunately, we made the diagnosis only when the patient went down to ultrasonography for something else, and I got a frantic call saying that he had 2 liters of urine in his bladder. So there are multiple risk factors for delirium. Some of them are unmodifiable or unpreventable, beginning with age, history of hypertension or previous cognitive impairment or alcohol use. Illness related, you can have a very severe illness, including the need for mechanical ventilation, and some are hospital related factors, lack of daylight and isolation. Some can be modified, sensory deprivation can be, all these metabolic factors can be controlled, and isolation and drugs can be managed. But these are all factors that we need to pay attention to. So when we assess these patients for risk factors for delirium, we should be looking at this list. Any one or multiple of these being present, and you need to be watchful. If you see it in that sense, testing for dementia or testing for consciousness should be the 6th vital sign. But unfortunately, it's neither standardizable. It can be standardized, but it's not easily reproducible. It's not very easy for paramedical staff to follow it. So follow-on interventions and so on are a little difficult, and that is why it's not generally measured. Ever since intensive care graduated to the point that this became important enough, so say from the 80s, 1980s, 1990s onward, there's been a fair amount of literature that's been appearing, and people started to put together these various systematized ways of testing for delirium, and I'll take you through a little bit of this. The first was the intensive care delirium screening test. if you look at the older literature, you will see this ICDSC. It is a little complex. It's a little complex, and you need to give points with the total score, and then obviously you make the diagnosis. And this you can even do for intubated patients by showing them pictures and showing them a wider array of pictures next time and finding out if they. But that obviously means that they have to be at least conscious enough to point at your diagram. But the more commonly used one, which came up a little later, was the two-step method. The two-step method consists of two steps. The first step is the Richmond agitation and sedation scale, and normally you may have seen these faces, the diagrams that are available on the nurses' sheets. So somebody who visibly looks angry and somebody who's absolutely flat, and you can actually number these. Then you add to this the acute onset of mental status changes of fluctuating course and inattention and disorganized thinking or altered level of consciousness, and you get this diagnosis of delirium. But as you can understand, again, these are not very easy to train paramedics or nurses to do, and even doctors, even if they are aware of it, are not going to be doing this on a regular basis. So the 3-minute interview kind of substituted for this. If you're asking the patient, then you ask the patient whether they have felt confused. You give them tests like digit span. So you give them, say, 5 numbers. Remember that all of us used to remember the 7 digits of the old phones. With 8 and 10, I find it difficult, but 7 digits I used to comfortably remember. So people should be able to remember 3 to 4 digits backward, days of the week backward, months of the year backward. Ask the patient to state the current year, the day of the week, type of place, etc. And there should be no altered consciousness. And if you get, we'll come to this a little later. Whereas if it is by an interviewer, find out if there has been fluctuation. Was the patient easily distractible? Was the patient unclear? Was the conversation rambling, sleepy? If all of this has happened acutely, then you have 1 point. And when you ask the patient to do these digit spans, again, you can see that you will be getting either features 1 and 2. These two should always be there, and either 3 or 4. And this can be either from the patient or from the attendant. And this is something that again requires training for nurses to do on a regular basis. Even doctors don't do it systematically. So what is it that we use regularly? For my own purposes, this test came out a little later, and this is called the 480. It consists of only 4 items. The first is alertness. Remember that somebody who's normal, fully alert, not agitated, is normal. If they are a little sleepy, they may be sleepy for about 10 seconds after you wake them up, but then they should be normal. Anything other than that is, if it is clearly abnormal, especially if somebody falls off to sleep while you are examining them, that is clearly abnormal. Then you ask them 4 simple questions: their age, their date of birth, the place that they are in at that time, and the current year. You will be surprised how often you turn up mistakes on these. 2 or more mistakes, 2 points. Attention, you use months of the year backward. If somebody gets 7 months or more correctly, 0, and then 1 and 2. Is this an acute or a fluctuating course? Then again, you get points for that. And you can see that somebody who gets 0 is clearly normal. Anybody who has anywhere between 1 and 3 is in a gray zone. And anybody who's 4 or above is either delirium or dementia. And you then need to work them out. Now, the problem is the 480 is that Of course, the advantages are that it takes less than 2 minutes and it doesn't require any special training. The problem is that patients remember these questions. So you cannot really use this for repeated use. It's a screening tool. So either you get delirium unlikely or possible delirium. Remember that checking attention alone is not enough. There are multiple mimickers of delirium. They include dementia, depression, and psychosis. Delirium is acute. All of these are plus. Inattention, altered consciousness, disorganized thinking, altered psychomotor activity are all there except for the chronic duration. Dementia, there is no acute change. There is no altered, but the others can be positive. Depression, there's altered psychomotor activity and chronic duration, but that's it. Some of them may be a little inattentive, but not otherwise. And in psychosis, there's disorganized thinking and altered psychomotor activity, but there's usually no change in consciousness. There is no change in consciousness. Now, the problems are that delirium is not objectively screened. There is the diagnostic terminology is a little confusing, and you can see from the scales that I showed you that except for the 480, the others are not very easy to use or remember. And more often than not, people don't understand the significance, cannot identify the hypoactive subtype because, well, too often people think that the patient is just sleeping. And as I said right in the beginning, is whose responsibility is it to identify delirium? How frequent is it? Actually, quite frequent. Post-operatively, in major abdominal cardiac surgery, it can go up to 50 to 70%. In the general medical wards, anywhere up to 30%. And in the ICU, anywhere between 20 and 80%, depending on the kind of patients you have. What about palliative care? Again, as you can understand, it will really depend on the setting. If you look at inpatient palliative care units, during admission, about 1/3 of people will have delirium. But by the period of their stay, it goes up to as many as 60% of them. In patients in oncology, not palliative medicine, just about 25%. And in the community, patients who are taken up for palliative care, as much as 55%. At the end of life, anywhere between 40 and 80%, depending on where the patient is. Obviously, inpatients are likely to be more ill. When you do have a patient with delirium, now this is a fairly nice algorithm, and I'll go through parts of this. So if you have somebody with delirium, the beginning is to start with supportive measures, hydration, avoiding restraints, mobilizing, reducing noise, reassurance, managing pain, so on. These are all basic general measures that we should be taking for all of them. Remember that in palliative care, one of the tenets is treat the treatable. Offending drugs, typically palliative care often discontinues all drugs that are not obviously necessary. Is there a history of trauma? Is there a focus of infection? And if indicated, then you need to begin antibiotic therapy. And if there is CNS infection, then again, depending on the palliative care situation, you will or will not perform a lumbar puncture. There are many drugs that can worsen delirium, and some of them are from our own armamentarium. So benzodiazepines can, opioids can, other sedatives can, but also anticonvulsants, antidepressants, drugs that are not often used in palliative care, such as histamine blockers, anticholinergics. These are also troublesome issues, and we need to look for substitutes here. If there is no obvious etiology, then think of vitamin deficiencies, and typically I would probably load these patients with B12 and folate and B1 if there's any history of any kind of deficiency possible, because B1 is potentially something that can lead to wernicke's. Thyroid should be tested for, and at some stage we do an EEG, MRI, drug levels, toxin screen. Again, these are not, it will really depend on the palliative care situation of that patient, depending on the prior level of functioning. Sometime in 2016, this guideline came out for the anesthetists, which was A, B, C, D, EF. So ABC consists of assess, prevent, and manage pain. And if need be, analgesia-based sedation techniques with fentanyl can be used. Um, if these patients are drowsy, then you need to do a spontaneous awakening trial or a spontaneous breathing trial. If not, then you need to move towards faster liberation from mechanical ventilation. Sedation has to be as light as possible. Typically, we avoid benzodiazepines. If at all something is necessary, then it is Dexmet. That has, of all the various drugs, that has the lowest risk of producing delirium. There are multiple non-pharmacologic strategies can be used. Early mobility is becoming more and more important in ICUs, getting patients out of bed soon, involving the family so that they are at least people who they recognize are around them. If the patient has visual issues, then you make sure that whatever is needed to correct it is done, or adequate hydration, nutrition, and maintain sleep-wake cycles. This is something that I find more and more important, especially in individuals who are borderline. If they're borderline, then it just seeing to it that they have clear daylight exposure, that they have exposure to bright sunlight for at least an hour in the morning. This really makes a lot of difference. Um, so you can try making them go to sleep with warm milk, massage. Some of this needs family education because, especially in palliative care, these are patients who will be at home. So the other thing that you need to do is reorient the patient repeatedly, and this is something that the family has to be told or the nurse. Um, you explain to them where they are, why they are there, and try and tell them what date it is, so that they know what they are. So they start getting reoriented. Mobilize as much as possible. Another rule is, as far as possible, avoid lying in bed if it is possible to make the patient sit up, and monitor bladder and bowel function. All of these are um, stuff that depends on family education involvement, and once that is done, you'll see the difference. Now, if the patient's behavior interferes with care or safety, then you need medication. And although there is not much trial evidence, the commonest used drug, especially in palliative care and for much other purposes, is a low dose neuroleptic, for example, something like haloperidol. Of the atypical antipsychotics, we find that haloperidol works best. The other drug that is often used is dexmedetomidine, and this is agonist, a centrally acting alpha 2 agonist that has both sedative and anesthetic properties, inhibiting norepinephrine release. So you load and then continue, but you can't give it for longer than about 24 hours because it can cause hypotension and bradycardia, and it is relatively expensive. So the mainstay of our management is actually haloperidol. Some reasons for it has the lowest anticholinergic activity, and anticholinergic activity actually worsens delirium because it blocks memory. It has fairly high potency, so you can use something like 2.55 milligrams IV and then shift down to 0.25 milligrams tablets. So typically, if it is needed to be given parenterally, I start with 2.5 or 5 milligrams. Hello, as a stat dose, and then come down on this. And you taper the dose as soon as possible. The important thing to remember, especially in patients with neurological problems, is that if there is any evidence of Parkinsonism, it can cause a disaster. What about the atypical antipsychotics? There's no convincing study, but risperidone, olanzapine, quetiapine, ziprasidone have all been tried, and the target is a manageable but awake patient. Probably quetiapine is the other drug that we often use because it has a fairly decent sedating effect in addition to its antipsychotic effect. So for me, the bulk of my management usually centers around quetiapine and haloperidol. Now, because these other drugs have other side effects that are difficult to handle, that's why we prefer haloperidol. But if the person has Parkinsonian features, then haloperidol has very severe extrapyramidal side effects and it is specifically contraindicated. In which case, then you will be using a drug with lower uh, extrapyramidal side effects like either olanzapine, quetiapine, or aripiprazole. If it is a little chronic and you have somebody who has Parkinsonian features and needs a potent antipsychotic, then the preferred alternative is clozapine, but clozapine cannot be used in an emergency situation. It has to be built up gradually. Okay, so we've done A, B, and C. Let's come to D. When it comes to delirium monitoring, ideally you need routine CAM ICU with the 3-minute assessments. But as I said, except for some specialized units, not everybody seems to be using them. Try non-pharmacologic interventions or DexMed. Early mobility and exercise is important. And in fact, I remember being struck about 5 or 6 years ago by um, uh, an intensive care physician from New York who showed us uh, as part of his talk, an 84-year-old woman who was intubated, was connected to the ventilator, and was actually being made to stand up and walk. And the last is to get the family engaged and empowered, because cognitive stimulation is something that they can do better than anybody else. So, my protocol for patients who are in delirium, where I think that there is a good chance of recovery, I ask for a daylight bed. This would mean a bed where they get full daylight through the day, if possible, even sunlight in the morning. Haloperidol, the tablet is 0.25 milligrams. I use 1 or 2 TID for 2 to 3 days, then BID for 2 to 3 days, then HS for 2 to 3 days, or taper it off. Sometimes, if the patient has been irritable, then you may even go on for as long as a month. But whenever I prescribe it with a specific limit. Instruct to hold if the patient is drowsy. And together with the haloperidol, use these two other drugs. Melocet, 3 to 6 milligrams at around about sundown, somewhere between 6 and 8 p.m., followed by quetiapine at bedtime. And you can use something like Modalert in the morning to actually pharmacologically reorient them. What can we do here? Well, as I said earlier, ICU nurses, residents, all need to be able to recognize delirium. We need to actually make this policy. I've been trying this at Hinduja Hospital. It's not really happening, where uh, the vulnerable, well, and the delirious have a priority on the daylight beds, not those who ask for them. And there should be a drug checklist. Basically, you have to check whether the medicine that the patient is getting, is it necessary today? For instance, a classic example is bladder drugs in a catheterized patient. And you have to eliminate or replace drugs with high anticholinergic potency in the vulnerable. Again, this is part of the same algorithm, and the outcomes are full delirium resolution, but a fair number of patients are actually, after a long period of delirium, left with long-term cognitive impairment. Sometimes some patients will have persistent delirium, and if this is refractory agitated delirium at the end of life, then you need to move to move quickly towards involving care for managing these patients. I'm running through the references that I have quoted specifically here, but if anybody sees anything else that you'd like to have, I think most of the papers that I've quoted are with me. But I'm also happy to share this presentation with the organizers, so you will be getting that in any case. And if anybody wants, my email ID and mobile number are here. I will finish. I think I'm just at 45 minutes, even though I started a little late. I will now stop sharing. Thank you. Hello, Dr. Sunil.
Sunil sir?
Hi. Yeah. Okay. So we had a case presentation.
Yes, sir. Dr. Sunil,
So
are you there, sir? Sir, before moving to the
Yeah,
case
yeah.
presentation, yes, sir, Dr. Sunil.
yeah.
I think we can have uh, any, if you have any questions, you can ask. Dating is a very
Okay.
important topic.
Sure.
So dating is very important topic. So if you have any doubt, please ask.
Right. Anything in the chat? Clonidine used for ICU delirium? Yes, it has been, but again, not much evidence and not really. At least I haven't used it on a regular basis at all. Thank you. So I don't think there are any questions. We should move on to the case and then amitriptyline causing delirium. Yes, it's got fairly significant anticholinergic activity. So I would be rather careful of using it. In any case, if somebody is delirious, then you really don't need to worry too much about depression. You can leave their brain to come back, and then we can worry about depression for them. Um,
Anybody?
yeah.
So I think we will move on to patient story and then we'll come back to discussion again.
Yeah. Yeah.
So that is yeah.
Okay. Let's have the
So
case presentation.
Dr. Kirtana will be taking the patient story today.
Okay.
Dr. Kirtana.
Yes,
Yeah.
sir.
Hi, Dr. Kirtana. Start.
Hi, doctor. Okay, now my presentation is on the topic delirium. And I'm working in a private clinic. I borrowed this case from one of my friend working in an institution.
Okay.
Can you please change the slide? Okay. And now the patient name is Mr. M. I have mentioned it like that. And now age is 54, male. And he was diagnosed with advanced stage lung cancer with malignant pleural effusion. And this case is about morphine-induced delirium. Please change the slide. The presenting complaints are the patient has come to the palliative care and he had grade 4 dyspnea, severe right side chest pain, dry cough, reduced appetite, nausea. He was started on oral morphine 10 mg per every 4 hourly and for right-sided chest pain. And later on switched over to the fentanyl patch as he developed dysphagia secondary to dyspnea. Cough was under control with cough suppressants and ondansetron 4 mg 3 times a day took control of the nausea.
Okay.
Present history of illness, Mr. M underwent fluorosis. He started having right-sided chest pain. The pain was very severe. Examination, dyspnea was present, pallor, and the patient was bedridden, and other vital signs are stable. Respiratory rate is 44 minutes per minute with oxygen saturation. Here comes the treatment. Palliative care, the patient preferred the palliative care instead of chemotherapy because he wants to be at home instead of staying in hospital. But since he had severe dyspnea, we advised him to get into the hospitals and was treated with bronchodilator and oxygen to nasal prong 6 ml per minute as he developed cyanosis. He had anxiety attacks during severe dyspneic attacks, for which he was started on tablet lorazepam 1 mg at bedtime. Psychotherapy drugs were used after the development of delirium following the use of oral morphine 4 mg. Psychosocial aspect, he did not have much psychosocial problems in his life, and he was aware of his diagnosis and incurable nature of the disease, and he had a very strong family support. He was worried about only his health condition and in mild fear of death. Patient was consoled and made him understand the treatment given a better way, and he started to cooperate little. The medications were because of using morphine, he slowly developed delirium. He had amputations, and the various conditions, including metabolic causes, were ruled out. And we started him on psychotherapy, that is with haloperidol 2 mg subcutaneously every second hourly, and midazolam 2 mg subcutaneously every second hourly. And still, fentanyl patch was continued for pain management, and metoclopramide 10 mg subcutaneously 3 times a day for nausea were administered. The patient is better now after this therapy. Please change the slide. And the main concern for the patient is to treat the delirium. He got agitated, and the patient was not aware of what treatment is going on. He started to throw tantrums, and pain management, dyspnea, to control the dyspnea. Please change the slide. So this case is about a morphine-induced delirium, and the patient was well supported and care was given. And it can be treated through, basically delirium can be treated with pharmacological, non-pharmacological measures. And we applied both for this patient. And identifying the problem at the right time may help to reverse the condition in both ways. And okay.
Right. So is that the last slide from you?
Yes, sir.
Thank you. So can we go back to the first slide? Okay, sorry, not the, yeah, go on. One more. Right, so anybody wants to comment on what are the possible causative features here? One is that I'll start off with one. The first is grade 4 dyspnea. This is an individual who's likely to be dyspneic at rest, probably cannot walk at all. And so one obvious cause that will keep coming up and which we can correct to some extent with nasal O2 is hypoxia.
Yes, sir.
Then what is the next cause of delirium here?
Pain.
Yes. So pain is a potent inducer of delirium. I mean, people can get delirious if the pain is uncontrolled. So you do need to do whatever you can to control pain. And as you can see, we ran into a problem there. What about the next? Next, it's there on the slide itself. Cough may cause delirium if the patient's sleep gets completely disturbed, cannot sleep at night, cannot lie down flat. Yeah, then the cough itself may be a cause for delirium. Next. Anybody? Nausea, reduced appetite.
Yes.
Right. So what do you expect with that? Dr. Gupta, you'd want to discuss this? Dr. Namrata Gupta, I think, answered that with nausea. So would you like to unmute yourself and discuss this?
Sir, nausea can cause, like, he will not be eating and be very frustrated.
Yeah.
Continuously having that feeling that he cannot eat also.
No, causing delirium and something that is correctable and treatable immediately.
Hydration may not be good and electrolyte imbalance may be there.
So this is somebody who has been ill for some time. Appetite has gone down. It's probably been given chemotherapy. Maybe there's a history of alcohol also. We don't know about that.
The patient had a history of chemotherapy, sir, but after a few days, he was not willing
Yeah.
for that, and his family members
Fair
were
enough.
not willing
So
for.
no. No. I'm looking for causes of delirium here.
Yeah, he had a history of chemotherapy.
Pointing. No, I'm talking of reduced appetite. So nutritional deprivation. We should not miss thiamine deficiency. I mean, this may not be obviously this is a patient with palliative care and is likely to probably not survive this illness, but if there is any survival possible, then you do need to supplement them with thiamine and vitamin B12, or at least make sure that they have adequate stores. Then, of course, we have this clear history of uh, morphine uh, actually causing delirium. So, I'm not sure if you people have dealt with opioid usages. If you have not, has that been taught yet, or it's yet to come? Opiate usage. Sorry.
Finished.
Finished. Okay. So what are the strategies that you can use if somebody has problems with morphine?
Anybody can answer if the patient. Yeah.
So we can change the opioid.
Yeah. So which one?
It's a methadone.
Yeah, methadone is good. Fentanyl patch was used here.
Patch.
Oxycodone is not regularly available, but yes, it can be used. They're more expensive, but I mean, if you have no choice, you have to use something other than morphine. Dr. Sunil, anything that you would like to come in with?
No, sir. Yeah. In the diagnosis, it was told that pleural effusion. Pleural effusion is a cause for delirium. It actually is getting that.
Go on. So next slide. Pleurodesis was done. So chest pain, yes, that would have been. That's a fairly painful procedure, and you're already having problems controlling his pain. So the pain itself is going to be adding to his delirium. Next. And he's got a very fast respiratory rate. He's pale. Next slide. Right. So obviously during all this period, he's very likely to be anxious, and you may require to be treating him with a benzodiazepine. Anything else? We often use quetiapine in the same way. Even haloperidol works on anxiety, though the primary indication is for psychosis. So again, these are all possibilities here. Next. Yeah. So aware of his diagnosis and the incurable nature of his disease. So this is, of course, something that would need counseling, and the palliative care team would need to give him spiritual support at this point, especially if it's not possible to do it formally. And as you can see, the patient begins to understand this and starts to cooperate. Next slide. Yeah. So at this point, when the delirium really got out of hand, then he needed to be put on haloperidol, and fentanyl was continued. And then with that, I think he settled down. Anything else, Dr. Sunil?
No, sir.
Anybody else has any questions, or we are ready to close? We're actually finished quite early.
Dr. Nina?
Yeah. Dr. Nina, go ahead. Shoot.
Sir, there will also be delirium at the end of life.
Yeah.
So how do we differentiate that?
Okay, so no, so terminal delirium, so then that becomes a part of the whole active dying syndrome. And this would be an individual who has declining intake, declining activity over a period of weeks to months, and then you come into this period of days where the intake drops very significantly, the urine output drops very significantly. There is peripheral hypotension, and at that stage, almost 100% of patients are in delirium. That is something that we treat only if it is hyperactive. If the individual is hypoactive, then we just make sure that pain and other symptoms are controlled. But if it is hyperactive, and especially somebody who's thrashing about, it's very disturbing for the family, and you need to sedate the individual for that. And if it is due to pain, then this may be one of the situations where you start to consider palliative sedation, where the aim is to give the patient comfort, but understanding that the risk is that you may be that the same medication may be hastening death. So terminal delirium is not uh, treated as such unless it is hyperactive.
Okay. Okay. Thank you, sir. Thank you.
I would like to know one thing, that for dyspnea in palliative care, we were told that morphine, 2.5 milligram BD should be started. And of course, this patient had pain also along with
Yes.
it. So should we have started with a lower dose first and gradually increased, rather than starting with a higher dose, and then it resulted in delirium? And what were his KFTs? We are not sure.
Yeah, that was not there in the. Yeah, good. That's a good point that you made. We don't know whether his creatinine was intact or whether it had really climbed up. So I think the therapeutic target here was the pain. In fact, if you see the dyspnea, although he had stage 4 dyspnea, that was never a predominant complaint. His complaints were different. So I doubt that I would do anything differently, except obviously, as and when possible, move on to an alternative to morphine.
Thank you.
Right.
So, as sir told, there are the diagnosis of terminal delirium is something which may be difficult for us to understand, because if you are seeing the patient for the first time and if the patient has delirium, you may not be able to understand if it's terminal delirium or something else, or delirium due to reversible causes. So, but if you are continuously seeing a patient, you know this patient is deteriorating, and then you can understand probably this is a terminal delirium. So, terminal delirium is a diagnosis mostly when you look retrospectively. But if you are seeing a patient continuously, then probably you will understand this is a terminal delirium. So, in terminal delirium, there are multiple causes and which are not often reversed, but otherwise the causes of delirium are reversible, and it may range from simple urinary retention, constipation, to maybe brain metastasis. So we have to first need to understand or evaluate the reason, simple reason for delirium. Rule out those things, and then uh, uh, you are unable to do anything for the patient. Considering the patient biological status, prognosis, etc., you may go on for further investigation. If the patient is near end of life, you won't do any uh, any investigation, which is going to be more harmful for the patient.
Right. So I think I'll close at this point, Dr. Sunil. I think we're done.
Yeah.
Yeah.
Yeah. So,
Okay.
anybody else has any more doubts or any comments?
Hello.
Yeah.
Sir, with malignancy, do we see more cases of delirium? I mean, the cancer patients, do we see more often delirium?
So, see, the highest incidence of delirium is when there is a primary CNS disorder.
Okay.
And say, for instance, if somebody has dementia, then they will be in delirium much longer. In fact, where the dementia ends and where the delirium takes over becomes a little difficult to define. But in cancer, you have something called, if you look, I mean, I'm not sure if you've seen the trajectories of dying. Have you seen that graph? It's a very standard, yeah. So if you look at the trajectory of dying from malignancy, that's called the waterfall trajectory. So patients maintain normal function till a fairly long period of time. And it is, say, for instance, the second chemotherapy fails, and then the malignant stage starts to build up, and then the patient starts to go downhill. So as the patient goes downhill, for a long period of time, the patient is neurologically intact, unless, of course, the malignancy is spread to the brain. But at the end, as the tumor burden grows beyond a certain point, systemic sepsis sets in. And that is the mechanism of active dying. So a cognitively normal individual getting systemic sepsis with overwhelming tumor burden, that is right at the end of life.
Okay.
Which is why in cancer you see terminal delirium.
Okay, sir.
But for instance, if somebody is dying of hepatic encephalopathy, so he's in and out of delirium all the time. You don't expect to see that patient normal otherwise.
Otherwise, okay. Thank you, sir. Thank you.
Okay. Anybody else?
So supposing
so
it
I'll
is a renal patient, KFT patient, and who has had a stroke also, and then is there more chance of going into delirium at the end?
Obviously. So because they have both CNS damage as well as metabolic encephalopathy. And you will see this as the patient, these patients will go very rapidly into altered sensorium if their creatinine starts to climb and so on.
Thank you.
Right. So I'll leave now. Thank you, Dr. Sunil.
Okay.
Thank
you, sir, for that wonderful session. And thank you, Dr. Kirtana, for